good evening, everybody. You're all very welcome to Med Cafe this evening, where we have something a little different for you. We have a webinar on total hip and knee replacement in the Netherlands, the Dutch decision protocols, no waiting lists. And very shortly, I'll introduce our two speakers this evening, but just to say they're both very happy to take any questions that you might have on the subject area, and these will be answered at the end of both talks. And as normal, just type your questions into the Q&A box, click submit, and we'll take these during the Q&A. Like I said, this evening's session is being recorded and will be available to view in the coming days in your on-demand section of your Med Cafe account, so please keep an eye out for it there. When you log off this evening, you will be presented with a short feedback form. And as normal, if you could just, you're always very generous with your feedback. If you could just give your thoughts on this evening's session. And if you have any suggestions for future webinars, please do post them into the feedback form, and we will do our best to get a webinar on that subject for you before the year is out. So it gives me great pleasure to introduce both speakers this evening. Our first speaker this evening will be Michael van Trommel, who is an orthopedic surgeon with more than 25 years of experience in treating the most complex issues in the knee. Patients from all over the Netherlands know how to find him and to treat their knee problems. He writes columns in the health section of The Telegraph, a leading Dutch newspaper. And our second speaker this evening is Johan Pot, who's an orthopedic surgeon specializing in knees and hips. He completed his training as an orthopedic surgeon in the Netherlands, followed by a period of work in Adelaide, Australia. He's now back in the Netherlands and works in a public hospital and in the Focus Clinic. He's committed to helping patients, including those who have been on long waiting lists, regain their mobility and improve their quality of life. And we're both delighted to welcome you both live in from the Netherlands. And I'm delighted to hand things over to you, Michael, as our first speaker.
Well, Will, thank you very much. And thank you all for listening to the Dutch treat that we do here in Amsterdam. We are located in and near Amsterdam with our clinic. This is a view of one of the canals in Amsterdam, very famous. And I think everybody knows how Amsterdam looks like. As Bill alluded, we are two orthopedic surgeons. We're a group of 7. This is 4 of our consultants, and we do only hips and knees, and that is quite different from your system, and that's important for this talk, because in Ireland there's the HSE for everybody, and of course private insurance for the haves, and for people who are privately insured, waiting lists are very short, and again after that they're good quality of surgery. But for the HSE insured patients, the waiting lists are very long, and in the end, of course, they will be helped very good. And we had this same system in the Netherlands until about 2000, with public insurance for everybody and private care in private clinics. And the government changed that system to a system where there's only one type of insurance for everybody, and the private clinics were changed to focus clinics, so paid by the same system for everybody. And with that, coming from the same system that you have in Ireland, over the years, the waiting lists have completely disappeared, or almost completely disappeared, because the previous private clinics, changed to focus clinics, did their work on a slightly higher pace and volume than the general hospitals, with a very good quality and the same reimbursement as the hospital. So that was not very good news for all the private consultants, but it worked very well for the patients. And now we have a very good working system with no serious waiting list, both on the hospital sites and the focus clinics. And we learned from Ireland where people are waiting very long. And as Ireland is a part of the European Union, many of you know that there is a directive from the European Committee. It's called the Cross-Border Directive, which means that every European inhabitant can have all the care he or she needs in every country. And initially, the HSE sort of blocked that a little bit because that's extra cost for them and extra work. But nowadays, they're very open to it. And even on the website of HSE, there's a part that explains how CBD works, and the Cross-Border Directive is there explained in steps, even with a short movie. And so patients who want to not wait any longer are eligible to cross the North Sea, fly to Amsterdam, and have their surgery done there. And now I know that there are many medical tourism organizations that help people get their surgery or their treatment abroad, but they bring you to Spain or to Turkey or Poland or whatever. And there you hope to find an English-speaking doctor who will help you in a proper manner. We are not a medical tourism agency. We work in a hospital. We are orthopedic surgeons. And in addition to that, we set up a small organization to help patients with the trip and get the cost covered by HSE and reimbursement via the credit union. We got 2 people in Ireland taking care of that. Having said that, I will explain in detail in the end very shortly how you can, if you want to send your patients to us, assume that they need a new hip or knee. But now let me first tell you how we decide on treating patients. Because we don't have these long waiting lists, we can sharpen our indications. In Ireland, with all respect, people are on waiting lists forever and they're really crippled by their complaints. So by the time they get to the surgery, they lost some quality of life. Hip and knee arthritis are quite similar in their symptoms. It starts with pain, stiffness, a limited range of motion, and sometimes a little bit of limping. And the problem with this is that these complaints have a very gradual onset. And people who have these complaints first reduce their activities to reduce their pain. And they sort of arrange their life around a painful joint. But to be honest, that leads to a reduced quality of life. I mean, you can live with a arthritic knee or hip, but it's no fun. And if you have to be on a long waiting list, you know this is going to happen, so you have to arrange your life around it. But if you don't have these long waiting lists, it's not necessary, and you can get your treatment earlier. But of course, the indication should be proper. You should have we don't operate everybody, of course. We have very strict indications because the waiting lists are not the main factor. We don't have to wait until the quality of life is largely reduced or the general condition of a patient is largely reduced. Let me give you an example of knee arthritis. I'm a knee surgeon. I do only knee surgery. And my colleague Johan will talk after me about hip arthritis. This is a very clear case. The first picture is a completely normal knee in a 55-year-old male. And the distance between the femur and the tibia is equally divided on both sides. That's a normal knee. The second X-ray, of course, is from a patient with no cartilage left and bone on bone. This is a complete end-stage arthritis from somebody who's been on a waiting list for many years. And the joint can be replaced easily because we do it every day. But if you're on a waiting list that long, because you simply cannot use your joint properly, your muscles decrease extensively in the power and ability to properly move. That means that after the surgery, your recovery time will be way longer than if you get your surgery done a little bit earlier. I'll go back to that a little bit later. This is a standard total knee replacement. I'm pretty sure we do it as good or as bad as our Irish colleagues, but only not with that long waiting list that you have. This is standard post-op view, front view and lateral view of a total knee replacement with resurfacing of the joint on both sides. There's a distinct subgroup with patients who only have medial arthritis. This is a right knee, and I don't know if you see my pointer, but this is the medial compartment. Here it's on the medial side, it's almost bone on bone, whereas the lateral side is completely normal. This happens in about 20% of the patients. Usually a younger group, people of around 50, maybe 55 years of age. And the reason why they come earlier is that if one side of the joint is affected, like here, the height of the inside part reduces and a little varus will exist, increasing the load on that single degenerated compartment. So because of the increased pressure there, this is a progressive disease, and the arthritis hits in much faster than on an equally distributed force on the joint. For these subgroup of patients who are in general, say 50 to 55 years of age, we have a partial knee replacement, of course, exactly as our colleagues in Ireland do. And then the surface is restored, just like a total knee, but then only on in this case, the medial compartment. And what is also important in this procedure is that the balance, a slight valgus, as you can see between the femur and the tibial bone, is restored. And a good balanced knee is very nice for patients, because then the attachment of the muscles is in balance, and you can put the forces on the knee in the way it's meant to be. These patients do very well, and in a good position, unilateral knee replacement, people say it's unbelievable. I don't even feel that I have a prosthesis. Whereas patients with a total knee in general are very happy, but they usually say, I can do anything I want, I got my normal life back, I'm very happy, but the knee itself is not my own knee. And I asked them for many years, but what is the difference in feeling? And they say, I can't say, but there is a difference. And in people with the unicompartmental knee replacement, there's absolutely in general, no different feeling. There is a takeaway message from the orthopedic point of view that I would like to tell you. And that is the old adagium or aphorism. It says, listen to the patient. He or she is trying to tell you the diagnosis. And that might sound a bit arrogant, but not all knees show complete degeneration on an X-ray. And the reason for it is this. On the X-ray, you see a little diminished joint space, but okay, there's some cartilage. And especially in a country like yours with long waiting list, this is a group of patients that will be sent away with physiotherapy, injections, painkillers, and wait and see. The truth is, the intraoperative picture on the other side. This is a patient I did about a month ago. I don't know if it's clear for you to see, but the central part of in this case, the femur, is completely gone. There's no cartilage there. But on the sides, there is some cartilage left. Bad quality, but there is some cartilage left. And the same, it's more difficult to see, is on the tibial side, where the central cartilage is gone, but on the side there's a little bit left. These patients have a lot of pain when they flex and extend their knee, but on the X-ray, you see still some moderate cartilage left, or some space left, because the cartilage on the side of the degenerated part keeps some distance, but these joints are very painful. And if you listen to the patient, he or she will tell you, this is not my life, I don't want it this way, I need some kind of a treatment. And the X-ray tells you something different, and this quite often happens. And because we don't have these long waiting lists, we quite often see this. And what I would like to tell you is, if you have a patient with a clear history of serious joint pain, consider them for surgery. Again, I don't want to talk everybody into surgery. Of course, the indications would be good, but this is a very important and often overlooked subgroup. Here is a short movie of how
The knee consists of the tibia, or shin bone, femur, or thigh bone, and patella, or kneecap. In knee arthritis, the cartilage on the end of the bones slowly wears away, causing pain and irritation, making daily activities difficult. Arthritis can affect all or just one area of the knee. In this case, the entire knee is affected and a total knee replacement is performed. During the surgery, your doctor uses a series of guides to help remove the damaged bone and prepare the femur, ensuring proper implant size and alignment. Next, your doctor will prepare the tibia using a series of guides to ensure proper implant size and alignment. The final tibia preparation is completed and a trial spacer is used to confirm knee stability. Next, your doctor prepares the patella to accept the implant. A trial implant is placed on the patella, and the knee is checked for proper implant size and stability. The trial implants are then removed, and the surfaces are prepared for placement of the final implants. Your doctor applies bone cement on the backs of the tibia, femur, and patella implants for final fixation. This completes total knee replacement.
In this short instruction, which you probably have seen before, the prosthesis is cemented. We use uncemented components, and the main advantage for that, it's a bit technical, is that the bone grows into the prosthesis. It is sensing that it's like a fracture, and by that the fixation between the prosthesis and the bone is very good, and we very rarely see problems with that. Only in very osteoporotic patients we use cement as an interface, but that's maybe more for a detailed story. Now I would like to hand over to Johan, my fellow consultant, who is very good in knee surgery, but is mainly into hip surgery. He will lead something about that. Thank you, Johan.
Good evening, everyone. So we'll continue on hip arthritis. Obviously also a common situation. Usually it's idiopathic or just because of older age. Obesity is not as big as a risk factor as it is in knee arthritis, but there is slightly increased risk in overweight patients. There's also a genetic precondition to get arthritis. And sometimes there are more rare causes of arthritis. So hip dysplasia, I'm going to tell a bit more later in a few slides from here. Hip dysplasia basically means a shallow socket and insufficient femoral coverage. Usually you see hip arthritis occur in younger patients with if they have hip dysplasia. Post-traumatic, also a common cause. Fractures, obviously, a previous fracture that was caused by an internal fixation or a trauma to the labrum or cartilage could cause post-traumatic arthritis. Another cause is avascular necrosis, AVN, or there's a few other names for it, but avascular necrosis basically means dying of a non-vital head of the femur. Main risk factors are steroids, chemotherapy, alcohol, and some systemic diseases. It's quite rare compared to idiopathic arthritis, but it can occur quite quick. So if you have an X-ray of a few months old and very progressive symptoms, take another X-ray. And sometimes you can see avascular necrosis. I have a few examples of that. Inflammatory arthritis is not as common as it was before, but in rheumatoid patients, you still see it. Obviously, the treatment for rheumatoid arthritis is a lot better than it was 20 years ago. So a few X-rays. So on the left side you see normal X-ray, normal joint space, and on the right X-ray you see joint space narrowing or a vanished joint space. You can also see a few other things. So you can see osteophytes, which is also a common finding on X-ray in arthritic joints. Osteophytes mean the sharp edges on the edges of the bone. And you could also see some degenerative cysts in the head of the femur, another sign of arthritis. So what is a typical clinical case of a patient with an arthritic joint, arthritic hip? So this is a case I did a few weeks ago, 78-year-old man. The typical pain is in the groin, sometimes deep in the buttock, usually occurs while walking. A lot of the patient will say my hip feels stiff, or I just can't walk as quick as I could. And usually the stiffness is in the first few steps or meters, and after that it feels slightly better. But after a walk of about 50 minutes, they will have increasing pain and have to stop for a while. Another thing is limited range of motion. So patients won't come to you and tell, well, my range of motion is limited. Well, they'll tell you stuff like, I can't clip my toenails or I can't tie my shoes, and that's another classical sign of arthritis. And by doing a physical examination, you will see a decreased range of motion, and the most typical finding is decreased internal and external rotation. Flexion and extension are usually not as badly influenced as internal and external rotation. And obviously, this X-ray shows bilateral severe arthritis. So about the young patients, hip dysplasia is developmental dysplasia of the hip, which basically means something goes wrong in the development of the hip. There's most of that happens intrauterine, actually. There are a few risk factors, mostly genetic, but also during pregnancy, position and stuff like that, and some other genetical causes. The anatomical results are a femur that is usually steep, so a high angle, but also a high anteversion angle. So the rotation is usually point a bit more forwards than average, and you cannot really see that on X-ray. You could see that in real life and also on CT scans. However, the most important finding in a dysplastic hip is a shallow socket. And a shallow socket means there's less coverage of the femoral head, so a lower contact surface and peak pressure, and thus arthritis. And a lot of those patients will come to your office or a clinic at age about 40 or 45 with severe arthritic joints. And this is an example. So this is a dysplastic hip, and you will see that the coverage, the amount of femoral head as coverage is there's not a great coverage area here. So, and the center of rotation, which is located here, is almost on the edge of the socket. On the right image, you can see also an arthritic joint with that, so the joint space is narrowed. This is a series of X-rays in a patient with osteonecrosis, and actually those images are taken not long after each other. So the left image, the symptoms started, it was not as bad, and the X-ray didn't show as much, but you can see some flattening of the femoral head, but a normal joint space. About 6 weeks later, progressive symptoms and a bit more flattening of the head, and then 6 weeks later you can see completely vanished femoral head. Obviously in the right X-ray, patient wasn't able to walk anymore. It was very painful, and you wanna treat this patient on a short notice, because you can really relieve those symptoms and give him or her his life back. So for a total hip replacement, there are a few different approaches or surgical approaches to place in a joint replacement. Anterior is nowadays the most common approach in the Netherlands. I would tell a bit more about that later. Straight lateral and posterolateral. Those are the surgical planes that you can see it that's a surgical plane from a surgical plane book. It's basically just different route to the same joint. And all surgical approaches have their advantages and disadvantages. So traditionally, the most traditional approach is the posterolateral, which provides good visibility. It's widely used, especially across the world. However, there's an increased risk of dislocation, and that's mostly in a movement that is similar to sitting. And in the first weeks, it's not uncommon to see dislocated hip. We can reduce it, but sometimes it occurs more often. So that's major disadvantage of the posterolateral approach. Another risk is the sciatic nerve is in the area of the operation, so it's a bit more prone to be damaged or temporarily paralyzed. The lateral approach has a lower dislocation risk. However, there's more muscular trauma and damage. So people after a lateral placed hip replacement will show more Trendelenburg gait, so limping. Usually the pain is all right, but people are not really happy with the limping. The anterior approach is muscle sparing, so and it's an intermuscular plane. The recovery is much faster. It is a bit more technical demanding because your visibility is a bit less. But if you do it often, it's actually not as bad as it sounds. It's really easy, and the main and except for faster recovery, hardly any dislocation. So we do this as a day case sometimes, not in the Dutch clinic, but in some Dutch clinics or hospitals, we can do it without staying overnight. So in our clinic and also in the Netherlands, it's quite popular. The anterior approach is standard, faster recovery, less limping, and less dislocation risk. And if you do them in big numbers, it's technically it's not as challenging. We do pre-op templating and planning. So especially in the younger patients in the dysplastic hip, but in all patients we do templating. So we see if we plan the surgery, how deep the socket should be placed, which femoral stem should we place, so we can choose different angles and different lengths. So we can restore the patient's anatomy when it comes to offset and leg length. We can also adjust the leg length if one leg is slightly longer or shorter than the other, but usually we try to restore the anatomy as it was. So this is what a knee replacement looks like. It's a few, there's a stem which goes intramedullary. It's placed without cement. There's a socket also without cement. Inside the socket or the shell, we have a polyethylene liner, and on the femoral head or neck, there's a ball which is ceramic. So the joint articulation is a ceramic head on a polyethylene socket, which is really low friction and low wear as well. So this is a short film about the anterior approach. So the approach is between the tensor fasciae lata and the sartorius. Then the joint capsule is removed. You'll see the osteotomy of the femoral neck is done, and then the socket of the acetabulum is reamed, and then the shell component, the outside shell is placed, and then the polyethylene liner. And then after preparing the femur, the stem is placed, and then after trialing, we can choose the definitive head for the femoral head and reduce it and close things up. You probably all have seen this during medical training, but I'm not sure how often the anterior approach is performed in Ireland. Postoperative rehabilitation and prognosis for total hip and knee replacement. So early mobilization is really important, and that really has changed in the last 10 or 20 years. So people start being on their legs 1 or 2 hours after the operation, full weight bearing with crutches, but they're allowed to put full weight on it. Physio from day one. Complications are, well, if you do them in high numbers, quite low. Infection rate is always a risk, but it's below 0 in the Netherlands. Dislocation, which is specific for hip replacement, is less than 1%. And fracture occurs very rarely. I haven't seen it in ages, to be honest, directly postoperative. Obviously, a late fracture after a fall does occur sometimes. Loosening of a hip replacement, I will show a bit more about hip replacement survival and then knee replacement survival. So in Holland, we have a very good Dutch health registry for about 50 years already, and all implanted replacements for hip and knees are put in the database, national database. And we can see the survival rate there in hip and knee replacements. It's about the same, actually. So 50-year survival rate, 93.8% for any reason. So a lot of patients will, at least in Holland, they come to me and say, well, my hip or knee will only last 15 years or so. And I say, well, then you're really unlucky, because almost 94% of the patient will do a lot better than that. If there is an issue, revision is, generally easy, or at least technically possible, and it's not a great deal anymore. And what used to be an issue in knee and hip replacements was the friction and the wear of the prosthesis itself. Since the polyethylene got a lot better, wear is not really as much as an issue as it was before. So in the hips, we see more and more that a fracture on a late age is the cause of the revision. So people had their hip replaced at 70 or so, and then 10 or 15 years later they fall and don't get a neck or femur fracture, but a prosthetic fracture, which is technically more demanding. But it is also a cause of revision, but it's not really a prosthesis issue anymore.
So thank you very much, Johan. That is how we, as a standard procedure, treat our patients. But of course, prevention of surgery is better than the surgery itself. So the general advice for all our patients are exercise against resistance, which basically means, well, walk as much as you can, but if you also can go to a gym, do some fitness and exercise against resistance with weights or on a cross trainer, those kind of instruments are very good in keeping up both your muscle power and the quality of your cartilage. Especially for knees, there's a straight relationship between overweight and knee arthritis, a little bit less with hips, but also there it's good to keep weight within limits and balance your food. There's no evidence that all these vitamins and so on help, but a normal balanced diet will do. It's not very special to prevent arthritis, but once you're there, we're happy to help. What is wise? Because we got all these words, how good do we do it? But we do it different from your country. In the Netherlands, the average age for a new hip or a new knee is 62.5 years of age. And as we know, we think, if you think about a patient or of a person who has a new hip or knee, that's an older patient, like 75 years or 80 years of age. But from the register, the mean age is 62. So that means that if there are people of 75 and 80, there are also people around their 50s. And that's what we do in the Netherlands. And in what Johan just showed was revision as an endpoint for any problem, but that is all patients together, also including teaching hospitals and those kind of surgeries. In a focus clinic, the prosthesis on average last more than 25 years. And that is because our studies run 25 years. We hardly see any revisions in properly placed prosthesis. Again, I want to stress, I don't want to talk everybody into surgery, but if it's necessary, there's no need to wait until you're very old and your quality of life is so much reduced. Now, something about the system. In Ireland, as I said, there are long waiting lists and no waiting list for the private care. We don't have difference in insurance, and general hospitals and focus clinic like the Dutch hip and knee clinic get reimbursed the same, which is not so good news for us, but very good news for the insurance companies and the patients. And with that system, the waiting list in my country have disappeared. As I said, under the Cross-Border Directive, which is a European directive, every European citizen, including Ireland, is eligible for help in another country. And I was in Ireland, sometimes there is these 50-plus fairs, and I talk to people of age, and they say, it sounds too good to be true. I mean, in Ireland, you have to be on a waiting list for several years, and you tell me that in your country, it's only, well, depending on the logistics to get you to Amsterdam, between a few weeks and a few months. It sounds too good to be true. But the opposite is true. I don't want to be unpolite about Ireland, but the insurance system in most European countries is that waiting lists are limited to a few months. It is the Irish system which has got the long waiting list. So to be honest, is not very special. And we have the capacity to help people from abroad. And we can do that. We are very open about this. HSE reimburses patients who get their treatment abroad. And the amount of money that HSE reimburses is higher, slightly higher than in the Netherlands. And for that reason, we can arrange the trip. We can even, I'll show it in the next slide, pay for the trip for an accompanying person. So you don't need to go there on yourself. And we arrange everything with the credit union, get the finance done. A small but important detail is that, as I understood, maybe I'm wrong, but I sorted it out. Somebody sorted it out for me. Even private patients can go under the cross-border directive with HSE. So even private patients can do it via the HSE because you're still covered by the HSE. What do we offer? Very practical. If you have a patient with an indication for a total hip replacement or a total knee replacement, please consider us. Maybe we can help your patients out. There's no need to wait that long, and there are so many patients in Ireland on a waiting list. It's not that difficult. We have a very clear and easy schedule on our website, and it starts when you refer to us with a video call with the patient and explaining them how we work and see if the patient is comfortable and needs a new hip or a new knee. And if we agree on that, we have some digital paperwork. We are paperless, but you know what I mean. We help with the funding via the credit union and afterward billing at the at HSE, and they reimburse directly to the credit union. We arrange the trip, the flights, and as I said, accommodation, including one companion. The only thing the patient needs to pay for is the flight, because HSE does not allow us to pay for the flight of the patient, which is 100 or 200 euros, but we will pay for the flight for the accompanying person. We are not a training hospital. We are experienced consultant surgeons. We only do hips and knees. And people come in on day 1, they have the surgery on day 2, and day 3, 4, and 5, they recover with us with physiotherapy and care, and then they fly back with a group of people who have been treated by us. After returning to Ireland, we provide and pay for, I don't exactly know, but I think like 10 sessions of physiotherapy, which is in our own interest because those physiotherapists are our eyes and ears, and if anything happened, we can discuss matter. As said, if you have anybody who is already on a waiting list or you consider for a new hip or knee, why not send it to the Dutch Hip and Knee Clinic? It starts with contacting us on our website, dhkc.nl, or send a mail to info@dhkc.nl and we'll sort you out. On the website, there are phone numbers from our Irish colleagues who work in Ireland, but as you might have noticed, we also speak English. The only difference between you and us is that the websites in your country end with .ie and in the Netherlands they end with .nl. But if you type that, you will find us and we can help you with organizing everything. Well, that is what we would like to say, and we are open if anybody has questions.
Thanks very much, Michael. Thank you very much, Johan. That was excellent, fascinating. And like I said, it's something a little bit different that we haven't heard on MedCafe before. So thank you very much. And there are some questions in, if you'd like me to read them out for you. Is that okay?
Yeah, sure. Wait, I'll just see if I can see them on light as well.
There's one here. What are the long-term results for uni-compartment knee replacement? Will unilateral osteoarthritis put pressure on and cause back pain?
Yeah, that's a very good point. If you have had a unicompartmental knee replacement and you end up getting lateral compartment arthritis, you need second surgery, obviously. But that surgery, from the orthopedic point of view, is your first total knee replacement. That's not a revision case with revision stems and all kind of difficult things. So you gain one with having a unicompartmental knee replacement, although, of course, it's surgery. The trick here is that we, as orthopedic surgeons, only perform the surgery if we are as sure as we can be about the other compartments. If we see something like, well, there's some bad weather coming up there on the lateral or the patellofemoral compartment, we won't perform a unilateral compartment prosthesis. But of course we do it, and sometimes after, 10, 20 years, people get advanced arthritis, it happens. And as said, then we change it to a total knee replacement as a primary procedure. The second part of the question was, is there a relationship between back pain and knee pain? The answer is there is no, but at the same time, people of age quite often both have a degenerated lower back and some sciatic pain in the leg, and also have arthritis of the knee. And it's a good sport as an orthopedic surgeon to really be very sharp on dividing the symptoms and see if the main issue is the knee or the lower back or the hip or the feet or whatever.
Right. There's another part of that question. So would you suggest an operation for medial compartment knee even without pain?
Well, pain is the primary and the only issue. It's the complaints of the patient. So if the patient says, okay, very interesting that I have some arthritis on the X-ray, but I'm doing well, there is no indication for a prosthesis. Of course, exceptions everywhere, but in general, there's no indication for surgery.
Right. Someone has asked, are these surgeries that you show the videos, are the surgeries you provide carried out by robotic surgery?
Yeah, I can answer that question. So robotic surgery or robotic assisted surgery is obviously quite in the media and the internet. And the robotic arm has been there for quite a long time. We don't use it, and I can explain why. Navigation and robotic arms have been around for quite some long time. It's getting more popular. However, the big thing is there's no difference in patient-related outcome and also not in survival. So it's a lot more expensive. It's a lot more technical demanding. It takes more time. There are studies that show you can increase your accuracy of placement, yes, but are patients more happy? No. So we haven't figured that out yet in the orthopedic world, to be honest. It's getting more popular, and especially in the private area. But the actual benefit for the normal patient without any difficult post-traumatic knee, it's not really there, the evidence there. So
and the reason for that is that the robot can help putting in the prosthesis, but the secret trick is the tissue balancing around the prosthesis, and especially in knee surgery, the balancing of the knee is very important. Even a young doctor can put in a new knee, but it will likely result in an unhappy patient because the tissue balancing is not optimal, and that will give pain on the long term. And robotic surgery nowadays won't compensate for tissue balancing.
Right. Someone asks here, is riding a bicycle good for knee and hip?
Yeah, well, yes, both in replaced joints and also in your own joints. So, we ride a lot of bikes, obviously, in Holland. So, and in patients with some minor symptoms of hip or joint arthritis, we actually recommend to go cycling and stay active. And usually, cycling is is better tolerated than walking, especially in obese patients. So, it's really recommendable to stay active and moving. Yeah.
Right. This is a long one, and some you might have already covered in your end of slides. How long will the patient remain in your clinic on average? I presume that's all in from the time they arrive to the surgery post-op. They say, I imagine you start the physio sessions and send the patients back to Ireland with physician instructions to follow themselves, or by referring them onto a local physio, or is that up to the GPs in Ireland to organise this?
Yeah. A good question again. They stay in the clinic for one night, and after that, although technically it's safe to fly home the day afterward, it's not very comfortable. And for that reason, they stay for a few more days, on average 3, in a nearby hospital where our own physiotherapist treats the patient, and where although it's not a hospital, where the nurses take care of the patient and we as doctors take care. After flying back to Ireland, we refer patients to the local physiotherapy. So that does not have to be done by the GP. What we ask from the GP is refer patient to us with an X-ray, and that I'm want to be specific about that, not the report of an X-ray, but the actual X-ray, because we really need to see what is happening in there, and report is not sufficient. And in addition, in the workup, our anesthetist needs some blood and EKG films of the heart and those kind of things. I don't know how that works with reimbursement in your country, but that is usually done by the GP.
Okay. Does the patient fly back to you again for follow-up in a few weeks, or where does the patient go when there is, say, an infection, or if there's any complications that they have when they come back to Ireland?
That's the obvious question. The follow-up is done. We ask the GP to get an X-ray after 2 months, although we never see a problem with an X-ray after 2 months. If there's a problem with a prosthesis, it's after 28 years. But okay, the question is get an X-ray after 2 months, and we do a video consult. And as more patients get their treatment abroad, it happens that there is a problem like an infection. Honestly, very rare, but everything can happen. And if a patient is treated abroad and goes back to my country, to the Netherlands, and has an infection, we treat them accordingly. And the same is in Ireland. If a patient has an infection, that is treated in the local hospital in conjunction with the medical specialists in the other country. That's the same everywhere in Europe.
As someone says, what is the rehab time post-op and how long until the patient can fly home? I think you just answered that. Is the follow-up done online? I think you mentioned that there's online consults as well. What are your opinions on alternative pain relief? Example, Circumin or type 2 collagen, or even knee brace devices?
Well, braces might maybe help a little bit in the mild arthritic patients, partly because they stabilize a bit. There's a psychological effect on it. But in my opinion, the big downside of braces and other helping devices are the very moment they give stability to the knee itself says, hey, that's great news. I don't need to do anything. So the quality of your stability, the quality of your muscles reduces greatly with a brace. In my practice, I very rarely advise on a brace. I only do it in patients who are not eligible for surgery because they have a very bad heart or very bad lungs and those kind of people. You mentioned alternative treatments like supplements. Well, we're surgeons. We never found evidence for supplements to be of any help when it comes to arthritis. Osteoporotic patients, they might benefit from some kind of calcium or other kind of medication, but that is the bone. We talk in this talk about the cartilage, which is adjacent to the bone, but it's different from the bone itself. And the cartilage itself, I don't think that can be influenced by glucosamine or other kind of supplements.
Fantastic. Someone has just mentioned that you talked about paying for a certain amount of physio sessions. They're just looking for clarity on how does that work on the physio sessions post-op?
We refer to physiotherapists for 10 standard sessions, and I think that's 45 minutes, but physiotherapists know that better than I do, and we pay for that. It's via the reimbursement of HSE, that's on our bill.
Okay. I hope that answered that. Thank you for this excellent presentation. Is there any limit of age for your offer in case knee, hip, total replacement?
Yeah, that's a good point. We follow the international rules provided by the American Anesthetist Academy. It's the ASA or ASA classification, and that draws a line at 80 years of age. But as we all know, there are people of 80 years who are very vital, and there are people of 80 years who are half dead, to be unpolite. And it's the anesthetist who has a separate consultation with the patient to assess the strength of the patient in terms of heart, lungs, and the ability to recover. So officially, the line is at 80, but it can be less than 80 if a patient is not in a good condition, and it can be slightly higher if the patient is in a good condition. On general, the line is ASA 2. That means healthy patient or a patient with one condition that is treated accordingly, like diabetes with insulin or hypertension with anti-hypertension medication, those kind of things. Say in general, if a patient can walk stairs without being exhausted, he or she is eligible for surgery. But that's an orthopedic way of saying what the work of the anesthetist holds. Yeah.
Great. Elsa, thank you very much for very good talks. Do you perform cruciate ligament repairs on the cross-border scheme?
Good question again. As a knee surgeon, I do a lot of anterior cruciate ligament surgery, but we don't do it on the cross-border scheme because the reimbursement is too little to accommodate for the flight and everything. That's too much work for that. So as of yet, we only do total hips, total knees, and unicompartmental knees. Yeah.
Great. Thanks for clarifying that. And one of the doctors says that the cross-border referral needs to come from a consultant as opposed to from a GP.
Yeah, that's not true. You can read it on the website of HSE. It can be either a GP or a consultant having a patient who is already on the waiting list. No, that's absolutely possible via a GP. 100%.
Okay. Someone else filled really good presentations. Thank you. If someone cannot locate a surgeon in Ireland willing and able to do anterior approach total hip replacement, will private medical insurance companies cover the same deal that was mentioned in your talk?
Yeah, the answer is that depends on the schedule they have with their insurance. And usually they need to pay something themselves. So that is really on an individual basis. But I'm almost certain that privately insured patients are also eligible under the cross-border directive via HSE.
Great. We're nearly coming to the answer. Do you have any idea on costs of this package, or including hospital stays? Do you have any idea on them?
Well, it's the HSE reimburses via a code, and that is exactly the same for the Irish hospital as it is for the Dutch hospital. So our back offices sends a bill with that code, and then HSE reimburses that. I don't know exactly what the amounts are. I think in my country it's around 10,000 euros, and in your country it's above that. I don't know the exact details, but that is also findable on the HSE website.
Yep. Excellent. That was really good. Thank you very much. And you'll read some of the feedback coming in there, which is great. And like I said at the start, you will be presented when you log off in a couple of moments. You will be presented with a feedback form. We'd be very grateful if you could just take 30, 60 seconds just to fill that out. And I know that tonight is something different for you. And we're very grateful to have two orthopedic surgeons live from the Netherlands with us this evening. So please give your feedback on this evening. We'd love to hear it. Like it is said, it is we haven't had a presentation like this before. And thanks to all of you for joining this evening. Thanks to those who asked so many questions. Thanks for turning out in such large numbers. But thank you to you, Michael, to you, Johan, for your time in the lead up to tonight's event. For your time you put into those presentations and your time this evening, it's really hugely appreciated. And I'm sure it's appreciated by all the audience here this evening. And we hope to welcome you both back onto Med Cafe sometime in the very near future. So stay safe. We look forward to chatting again. And good evening to all the attendees. Take care.
Bye-bye.
Thank you so much. Thank you.